I'm going to talk about cord blood transplantation. I know not everyone is very familiar with the use of cord blood as a source of stem cells, so I'll try to give a little bit of a background. I obviously can't talk about everything that we're doing, and I'll try to be leaving some room for questions at the end. I talk very fast, so I'll try not to do that. I'm just very excited about the work that's going on, and hopefully at the end of this you will be pretty excited as well. So, okay, so just as by way of background, cord blood can be used as a source of stem cells for bone marrow transplants. It's an alternative donor source still, but I'm going to show you data to suggest that this may at some point be the preferred source of donor cells when a patient needs a stem cell transplant. So this is fairly established now. We still have patients who come to the center. We still have many people who don't even know that cord blood can be used for this purpose, and patients in particular will come to the center and there's a lot of like mumbling and like, oh my goodness, you're getting a cord blood transplant. So there's a lot of, still a lot of myths that are involved in the use of this stem cell source, and I hope to demystify it all for you. It is very true, even though we've been doing these kinds of transplants since 88, that cell dose is still a huge barrier that we need to overcome to make this a better source for stem cell transplantation. And we need to overcome the cell dose barrier in order to be able to improve clinical outcomes. I'm also going to give you an update on our current cord blood program here at the Hutch and the SCCA. And I'll talk a little bit about our current clinical outcomes here and elsewhere with a focus on here. And then I'll talk about my true love, ex vivo expansion of hematopoietic stem progenitor cells. Okay, so cord blood transplantation is not new. Over 20 years, we've been doing this now. And in the first decade, I think really what we found with this source of stem cells are some advantages, distinct advantages and disadvantages. This decade really was a proof of principle that we could take stem cells collected from the cord blood of an infant, and we could actually use these cells to provide long-term hematopoiesis in a recipient after transplantation. The first patient was a young boy with Fanconi anemia. He's still alive today, and all of us who were at the 20th anniversary conferences for cord blood got to hear him talk about his experiences being flown to France in order to get his sibling cord blood infused into him. So the other real distinct advantage of this source of stem cells is that it's easy to get. There's no risk to the mother, there's no risk to the infant. Baby's born, the cord is cut, you collect it right there. And we have people who do this sitting here. So there's decreased donor attrition, so the cord bloods are frozen, they're already HLA typed, they're ready to go, they don't move, they don't change their mind, they don't go on vacation. So it's a wonderful source. So if you're a patient who has a very high-risk disease and you need your transplant yesterday, you need to have that donor available and ready to go when you are. So it's renewable, obviously, and in fact, I think the vast majority of cord blood is still thrown in the trash. So hopefully we can all work together to make that not happen. So as we collect more and more of this and it goes on the shelf, we expand our donor pool. And this is particularly important for patients who are of mixed ethnicity background or minority background, or patients who are Caucasian and happen to be in the 30% who cannot find a conventional adult volunteer donor. And the reason this is so important is that cord blood, because of the naive immune system that's associated with it, there's better HLA tolerance. And I'll talk a little bit more about that. But that is incredibly important. So if you're a patient who can't find a conventional donor, 99.5% of the time, we can find you a cord blood donor to allow you to move forward for transplantation and have that hope of a cure. The other thing that became very quickly apparent with use of cord blood was that there is decreased chronic graft versus host disease. And this, I'll show you the data, and this is still panning out to be true. So these were all the things that were looked at to be distinct advantages in that first decade. The disadvantages, though, this is sort of like the top 10 list, and number 1, 2, and 3 on my list is low cell dose. So this really is a problem, right? So when you're collecting cord blood from an infant, you only get about a cup of blood. And what this translates to for transplantation for an average-sized person is that that individual who is receiving that unit as a source of stem cells will get about 1/10 the number of stem cells for that transplant. And really what we saw that equate to was delayed hematopoietic recovery, both for neutrophils and for platelets. And we also saw increased graft failure. So the first reports for cord blood transplants, especially in adults, were quite dismal. There was up to 50% of the patients who failed to engraft at all, or they died before they actually did engraft because it took so long for the neutrophils to recover. So that led to increased transplant-related mortality, or TRM, and decreased overall survival. The other thing that was thought to be a disadvantage, although I don't hold this to be so true, is that it's a one-time donation. So you can't go back to that kid who's now running around and ask them to donate more lymphocytes if the patient were to need a donor lymphocyte infusion. And the other thing that was very apparent early on was that it was very difficult to find one unit that provided an adequate cell dose if you were a large child or an adult. So the second decade, which we're just now finishing up, really was a time when there was the first national cord blood transplant trial, the Cobalt Trial. And really the highlights of this trial were that the adult cohort closed early due to excessive mortality. And that's because we didn't know at that point what the bare minimum number of cells we needed to do that transplant with a single unit of cord blood. So these patients were being done with very suboptimal doses that we know now, and we didn't know then. And we did partake in that trial. This was before I even entered into the cord blood world. And we enrolled some of the adults in that arm, and it closed early. And for a lot of the clinical faculty who were involved in those first cord blood transplants here, when I started talking about reviving the program here, I got a lot of, why are you doing that? You know, they had a lot of post-traumatic stress disorder associated with that thought. So in the pediatric despite the fact that these kids were getting good cell doses, there was still 20% primary graft failure. So there were clear issues that needed to be overcome, but clearly if we could overcome those issues, this was a good donor source. This was also the decade that came out with multiple papers. I listed some of the more important ones where we were able to discern a minimum cell dose that was required for a TNC. So you can see that there. It's 2.5 times 10 to the 7th. This is what we talk about in cord bloods when we're looking at donors. We look at cell dose. So 2.5 times 10 to the 7th TNC per kilogram of body weight. So clearly if you're a 10-kilo child, not so difficult to find that dose. But if you're a 100-kilo adult, it can be very difficult to achieve that cell dose. And this is really borne out to be true in many, many papers. The first one really was by Mary Laughlin in the New England Journal. And then looking after infusion, looking at the cell dose for stem cells, and these are all about at least a log less of what you see in a conventional transplant setting. So CD34 stem cell dose, the optimum dose that you want to achieve in order to have good outcomes is about 170,000 per kilo. And again, that's far less than we would see in a stem cell, a peripheral blood stem cell or marrow transplant today. So we knew then after this decade that cell dose was very important, but HLA was also important, and there were roles for both of these. The big thing that still remains an issue is that there's delayed hematopoietic recovery and immune reconstitution following cord blood transplant, and this really remains a problem for those patients who want to get a cord blood transplant. So here we are now, entering into the third decade of cord blood transplants. And the way I see the big issues with cord blood happening now is now we need to think about strategies to overcome the obstacle of low cell dose. And hopefully if we can overcome these these low cell dose issues, we can improve engraftment, the kinetics of engraftment, and hopefully also improve immune reconstitution. So I'm going to focus a little bit on the next few slides about some of the strategies that have been developed and are currently in use here and other places around the country and the world. So these are the two things I'm going to talk about. The first one I'll talk about is infusion of multiple units of cord blood and how that came to be, and then I'll talk to you about ex vivo expansion of cord blood stem cells. Clearly these two things are a bit at odds because if you can just give more than one unit, there's really no point to the research that I'm doing and spending all this money in the lab and trying to develop ways to expand in number, the number of cells that are available for a patient. But I will show you that infusion of multiple units of cord blood has really changed things for patients, but we're still behind in terms of hematopoietic recovery. Okay, so double unit transplantation was really pioneered by the University of Minnesota. And the way the story goes is they were all trying to decide how to overcome this low cell dose. They had investigators working on ex vivo expansion, but they weren't really able to expand the number of CD34 positive cells. And then they said, well, how do we even know? Maybe there's something inherent about a cord blood unit that even if you give more, maybe the recovery for neutrophils and platelets is still going to be very delayed. And so what they said was, let's go backwards and do some proof of principle concept studies. And if we give 2 units of cord blood, you're always giving more cells. You're always giving more stem cells, and you're always increasing the TNC. And then you might be able to get some of these adult patients to get their transplants who otherwise wouldn't be able to do that, and see if that actually made a difference. This is what I call my love triangle. This is actually what I sit down when I meet with patients. I actually draw this for them on a piece of paper. I think this is, it's quite confusing. So for a patient who comes to us needing a cord blood transplant, the vast majority, unless you're a small child, will get 2 units of cord blood. So the way this looks and what we're asking is 2 better than 1? Is more better? So you have the patient, but you also now have 2 donors. Instead of there being in a conventional transplant setting, the patient and the donor and the 2 immune systems of these, right? So now you have 3 people at odds here. So you have recognition, and these donors are not perfectly matched to each other. In fact, they're highly mismatched grafts to each other and to the patient. So the way we choose these donors is we look only at HLA-A, B, and DR, at high resolution DR and intermediate resolution at A and B. And so we only match them at a minimum, or 4 out of 6, 5, or 6 out of 6. The vast majority are 4 out of 6. So these patients may be matched 4 out of 6 to donor 1, and donor 1 may be matched 3 out of 6 to donor 2, etc. So you have a very complex situation going on here. And when they first did the double unit transplants, I don't think anyone really knew or understood what would happen. Would they both survive? Would the 2 donors duke it out and neither of them survive and cause overall graft failure? And then in the end, what actually ends up happening, on the vast majority of patients, 1 donor goes away and 1 donor becomes the dominant donor. And this happens very early on. And now that we've done more of these, I think this interaction between the 2 donors is incredibly important for the outcomes that we're seeing. I think this interaction does lend itself to decreased relapse risk, and I'll show you some of that data, but it's a very fascinating phenomenon. So by day 7, when we look at these patients, you'll see only 1 donor there. It's as if you've never infused the other one at all. But it does seem to enhance the engraftment capacity of the other unit. So even though it's a very small unit, if it was used alone, now all of a sudden it can engraft. The early data was incredibly important and very encouraging. So this is a figure from the first paper that was published by the University of Minnesota on double unit transplant recipients. There were 29 patients included in this figure out of a total N of 31. 2 patients died before engraftment. But the important thing to note here is that all of the patients who were evaluable for engraftment engrafted. This was a huge step forward for adult cord blood transplant recipients. And keep in mind, these are all patients that could not have gotten a single unit cord blood transplant because none of the units were big enough. So they had to get the double in order to actually go on to their transplant. And the double combined dose is often as big as a single in a pediatric patient. So this was huge. However, what you can see is that the median time to engraftment still remains prolonged. Now, there are some earlier engrafting patients, and marrow still takes on average about 3 weeks, but the range can extend out to 41 plus days. So there was still a problem that we didn't overcome the delay in hematopoietic recovery, and platelets are still a huge issue, but we are now able to take adult patients forward for transplants because they will engraft. So really this initial work proved that we could do this and it was safe to give dual donor transplants. And we now have extended this to the use in reduced intensity conditioning regimens for patients who are older and not just in a myeloablative setting. The double unit transplant has extended access to stem cell transplants for adults with no conventional donor. And depending on where you are, what center you're at, you may go from a sibling straight to a cord, or you may go from a sibling to look for a conventional adult donor and then maybe to a cord. So here we're still on the more alternative side. So we also know that there's improved incidence of sustained donor engraftment, again, being very important. There's also increased incidence of acute grades 2 to 4 graft versus host disease when we do these double unit transplants, but they still remain quite, the GVHD remains quite responsive to steroids. So despite the fact that there's more acute GVHD, it's responsive generally to therapy, and chronic GVHD still is not any worse. And in fact, it's lower than most conventional donor sources. The big question that we're now trying to evaluate, which I don't have a lot of time to talk about today, is whether the dual donor enhances graft versus leukemia and decreases a patient's risk of relapse. And I'll show you some clinical data to suggest that that might be true. However, we still have this continued delay, and that's really the focus of my ex vivo expansion work. So there are questions that remain. I've already talked about this, the role of interaction between the donors and the host. We recently have a paper that's now in pre-publication status in Blood. John Gutman is the author on this. He just left, actually, sadly, and went to University of Colorado to start a cord blood program there. But we looked at the immune-mediated mechanisms behind the single donor dominance. You can look at that paper if that's interesting to you. And Stan Riddell is now working with us with another fellow to look at whether this dual donor interaction does reduce the risk of relapse and somehow enhance GVL. So we also want to look at the role of double unit transplant and the effect on immune reconstitution. And importantly for my work, the use of double unit transplants, now that we know that this is safe, really provides a platform for people like me who are trying to do immunotherapy or ex vivo expansion, because now we can essentially play with one unit and transfuse another unit that's unmanipulated and know that we still have a source of stem cells there. Okay, so this is really what happens in the lab. We can expand these cells quite a lot. So ex vivo expansion. All right, so this story actually goes back well before me. I certainly don't work in a vacuum. And when I was a fellow, I started work in Irv Bernstein's lab at the Hutch, and he is a Notch biologist. Now, I actually started doing work with AML stuff and was not doing anything with Notch. And it was while I was there, though, and continuing on with my fellowship training, that I realized that there are important potential clinical applications for ex vivo expansion of stem cells, namely in cord blood transplants. And in Irv's lab, they had already potentially identified a role for Notch signaling in self-renewal of stem cells. This was initially suggested by work done by Laurie Milner in his lab, where they found the expression of the Notch gene in hematopoietic stem cells. We also know that Notch ligands are expressed in the bone marrow endothelium, so we know that osteoblasts will express these ligands, and we know that hematopoietic stem cells have Notch receptors. So one thing that does remain unclear is really what the role of Notch signaling in vivo is. Most of the work that we have done is with manipulating this signaling pathway ex vivo, but certainly we can manipulate this pathway to cause self-renewal, at least of a short-term progenitor. So initially, after that first work was done, folks, Barbara Varnum-Finney in Irv's lab in this Nature Medicine paper in 2000, they did some retroviral transductions of the intracellular domain of Notch1, which is shown here. So here it is. This is the ligand. So they transfected this intracellular domain of Notch1 into primary murine stem cells, and lo and behold, when you had constitutive activation of Notch signaling in these primary murine stem cells, these cells behaved like stem cells. So they were an immortalized stem cell line. When we transplanted them into mice, they gave rise to lymphoid and myeloid engraftment. And so this was the first real indication that maybe we had something here. From there, we went on to develop engineered Notch ligands, because if you want to do this clinically, you can't really transduce the Notch intracellular domain and give this to people. So what we wanted to do was generate engineered Notch ligands, cartooned here. So the one that we use the most is delta 1, and we call it XIGG because it's attached to the FC domain of human IgG, and it's fused to the extracellular domain of delta 1. So essentially, we use this ligand to induce Notch signaling in the hematopoietic stem cell. And we've been able to show ex vivo that we have multi-log increase in the number of both murine and human stem cells. So this was really the foundation for a lot of the clinical work that I'm going to show you. So for those of you who are involved in translational research, you know that this is a very, very long process. So you can see that paper was published in 2000, that first paper showing that when we did constitutive activation of Notch signaling, that we actually caused immortalization of a stem cell. And now it's 2010, and we have a paper just coming out in some of the clinical work. So in 10 years, it's taken us that long to actually translate that work from the bench to the bedside. And this slide probably represents about 5 years of my work. So when I came onto the scene, we knew that we could take these proteins, these engineered ligands. We knew that we could adhere them to the plastic surface of tissue culture, either flasks or bags. And what we do with this system was in optimizing it, we take cord blood cells, and in the clinical setting, we thaw a unit that's been chosen for a patient, and we do an Isolex selection, which unfortunately Isolex is going to be no longer, which makes me very sad, putting our trial on hold. But we thaw this unit, select out the stem cells, and then we can culture them in serum-free conditions in a closed system with high concentrations of cytokines. I'm only going to show you 2 or 3 slides on the preclinical data because it's all getting published. But really what we were looking for initially was to prove that we could reliably take 34 positive cells and literally put them on top of this ligand. And in my simplistic way of thinking about things, what we wanted to show was that if you induce Notch signaling in this receiving cell, you're tricking that cell into thinking that it may be in the bone marrow microenvironment. And we tried to give signals to tell that cell to remain immature. And so what we looked at for our readout was 34-fold expansion, and then functionally we put these cells into mice to show that they could actually give rise to both lymphoid and myeloid engraftment. And this was really the foundation for writing the IND that would let us go on to do the cord blood transplant trial. The goal here was not necessarily to provide long-term engrafting cells in these patients. The goal for us was to generate a lot of cells that could be given to patients so that we could give them an initial wave of white cell recovery. It really was about decreasing the transplant-related mortality. Now, sure, I'd like to say that I can actually expand true long-term repopulating cells and true stem cells, but I can't tell you that for sure at this point. And really, clinically, that was not the goal. We knew we could give patients 2 units, and 1 unit would be the long-term engrafting unit, and it was always our expectation that these cells were meant to be a bridging gap. So we were meant to give them rapid neutrophil recovery so they didn't die of infection before they could engraft. So this is, again, the preclinical data. It's coming out this month online. So this shows you that when we take cord blood 34 positive cells that have been enriched, and we culture them in the presence of ligand, delta-1x IgG, or control IgG, that we average about 250-fold expansion of the 34 positive cells. This was a big aha moment for me when I was in a lecture of someone else who was doing some stem cell cord blood expansion work. And their average fold expansion, they were very excited about their 4-fold expansion of 34 positive cells. So I sat in that lecture when I was in the middle of all this work and thought, actually, maybe we have something here. And then in the control setting, we even had about a 60-fold expansion. But what really counted here was that functionally, when we put these into immune-deficient mice and followed for human engraftment, the cells that were cultured in the presence of IgG just did not perform as well as those cultured in the presence of delta. So this is a slide that looks at the mean level of human engraftment. So on this axis here is CD45%, so human engraftment in the marrows of recipient mice. So I need to get a picture of this, but I don't do this. We have wonderful technicians who can actually do bone marrow aspirates for me on these individual mice, so we can follow them serially. They take little TB syringes and go into the knee joint of these mice and then can tell me about we can look for human engraftment. So this has actually been wonderful. And you can see here that when we compare groups of mice that received delta cultured cells versus control cultured cells, or those that were not cultured at all, which is the clinical setting, that at 3 weeks' time, the human engraftment was overall much better in those that received the delta cultured cells. The gray bar represents the myeloid engraftment and the black, the lymphoid. And this is still commonly what we see, that over time, the contribution to engraftment expands from the lymphoid contribution. Those cells are probably peripherally expanding. And then we also still have myeloid engraftment, and that it's still statistically significant better than our control cultured situation or the non-cultured situation. So this was very important too in moving forward with the clinical trial. Okay, so I'm going to make you wait until the end to hear the actual punchline for the expansion trial. I have to make everyone stay. So the cord blood transplant program, I'm going to give you a little bit of update on what we're doing there. So I started opening up protocols in April of 2006, so we're going on 4 years now. And as I said initially, people were like, why are you doing this? And the reason I was doing it was not just because of my expansion work, but I knew unless I had a cord blood program here, people weren't going to come here for my expansion trial. So we needed to gain more experience in the adult world. In pediatrics, I'm a pediatrician actually by training, and in pediatrics we've been doing cord blood transplants the whole time, but not in the adult world. There were no protocols for this, and it was not being done. And if you were an adult who wanted to come to the hutch and you needed an alternative donor, you were often sent somewhere else, especially if you didn't have a haplodonor. So I opened up a bunch of protocols. These are the 5 protocols that are currently open for accrual, and this is only for hematologic malignancies. We do also have some protocols for non-malignant diseases as well. Protocol 2010 is a fully ablative. This is a fairly standard TBI-based regimen that we see in cord blood transplantation. It's a very high dose of TBI. The expansion trial is exactly the same by design. I wanted to have a cohort of patients that I could compare the results with. So it's exactly the same conditioning regimen, post-transplant immune suppression regimen. All of it is the same, except the patients on the expansion trial get 1 unit that's been manipulated in the lab. 2239 is a reduced intensity trial, and that is really primarily aimed at patients who have comorbidities and can't get a fully ablative trial. And then we're doing a randomization with the BMT-CTN, looking at single versus double in pediatrics, because the question there is even if you have a single that's adequate, maybe getting a double is better. So this trial is set to close in about a year, and hopefully we'll have some information on that. And then one last trial that we just recently opened about 10 months ago or so is Protocol 2275, and it's the first use of a triosulfan-based regimen in the United States for cord blood transplant recipients. So this just shows you that we really are increasing the number of cord blood transplants we do at the Fred Hutch. As I go to more and more conferences, when I went to the first conferences down here, people were like, oh, really, are you going to do them at the Hutch? And now I can say, yes, we really are. There are patients who are coming here for these trials, and I think I'll show you the results. They're actually quite encouraging, the results that we're getting here. This is our donor selection algorithm. It really biases patients towards getting a double, and some of that is a reflection on my belief that I think having a double may be of benefit for patients. And so you can see that as the match grade goes down, so as you have a more mismatched graft, we feel that higher cell doses will overcome the effects of mismatching. So the only way that you can get a single unit perfectly matched cord blood is if you have a cell dose of 3. So generally speaking, not many patients have that. Not many patients have a 6 of 6 cord because these are difficult to match patients, and most don't have a cell dose of 3. So for a 5 of 6, we require 4, and for a 4 out of 6, we require a single cell dose of 6 times 10 to the 7th TNC per kilo. We used to say that all patients who had 4 of 6 matched cords required a double, but that really called into question giving kids really, really large units if they didn't need that. So this definitely biases towards a double. So far, as of, I think about 2 or 3 months ago, we had enrolled 107 patients since February 2006, including 10 non-malignant patients. These are all comers. We have about almost half of our patients are from minority background, and we've enrolled most of them on protocol. There are many reasons why patients don't go on protocols, insurance, whatever. Most of the time it's insurance. We'll still do those patients, but we do them on treatment plans. And so you can see that the vast majority of our patients are getting myeloablative type regimens. About a third of them are pediatric and the rest are adults. So it's been a nice experience for me. I've gotten to work with my adult colleagues quite closely. So this is a recent publication from our center. As we started doing this, we realized that the cord blood transplants, we really had very few relapses. At the time of this publication, we only had 1. And so John Gutman, again, the fellow who was working with me, we decided to look at a matched cohort analysis. He spent a lot of time really matching these patients with excruciating detail, looking at matched related, mismatched unrelated, and cords, all at our institution. So I will acknowledge it's a very small series of patients, but what you can see here is the incidence of relapse was far less in the cords versus the mismatched unrelateds and the matched unrelateds. And TRM, however, was not very different. And so really what this meant was that the cords at the 2-year point were having better overall survival. So the cord overall survival was estimated at 74.5%, with mismatched running at 50 and the matched unrelateds at 60. So you can see this is very encouraging data, and hopefully the trends will continue. We have now joined together with Minnesota. Minnesota, some of my colleagues there, they were about to go to the Eurocord or CIBMTR because they only do cords there. So they couldn't do an analysis like we had just done because really they have some SIBs and then they have cords. They didn't have any conventional unrelated donors to really compare their results to. So I had suggested that we combine together because we clearly do a lot of conventional adult transplants. So we got together to look at double unit in particular, no singles in this setting, and compare them to conventional stem cell sources. Recently, Mary Eapen at ASH last year had presented some data to suggest that in the single cord blood setting, outcomes were very similar in adults, regardless of what kind of matched or unmatched donor you had. So we wanted to hypothesize that use of double cords would also lead to the same results, at least, and that these would be similar outcomes with both related and unrelated donor sources. We decided to stick to one single preparative regimen, which we think is a strength of this analysis. So all patients receive Cy-TBI. In addition, the cords receive fludarabine as an additional immune suppressive reagent in the thoughts that this really does help with engraftment, and all patients received post-transplant immune suppression with standard immune suppression. So one of the things I just want to point out in this analysis, you can see here, Minnesota contributed most of the double cords. We still contributed about 20% of them. But in terms of the conventional unrelated donor sources, they were the vast majority from our center. I do think this led to some center bias in the data analysis, which I'll show you, but we couldn't tease that out statistically. So again, these were all patients with hematologic malignancies, and what you can see is this is not surprising. This is very consistent with what we've seen with other papers that have come out before. The double cord is still statistically different in hematopoietic recovery. You can see here neutrophil engraftment is still at 26 days for this group of patients. Platelet engraftment really needs some advancement here. These patients are not necessarily transfusion dependent, but you can see that the double cords by day 100, still about 50% have not achieved an independent platelet threshold of 50,000 as compared to the other SIBs, matched and mismatched unrelated donors. In terms of GVHD, acute GVHD grade 2 to 4 was as expected. The SIBs and the double cords are running almost overlapping. Now this is where I think the data gets a little bit tricky because our center, as you know, most of our patients actually are diagnosed with GVHD at some point. I think there's been some papers out there to suggest that our center has much higher rates of GVHD. We look for it and diagnose it. And the cords were from Minnesota. So there may be a bias in this, but this is very consistent with what other people have shown. Chronic graft versus host disease, again, this is consistent with what we're seeing here in our cords. The double cords are far less than other conventional sources. And the interesting thing about the kinds of graft versus host disease that the double cord patients get, they get more of a relapsing acute type picture, and we just don't see the same kind of chronic extensive GVHD in this patient population, which is nice for the patients. So here's the problem. The double cords, when we look at non-relapse or transplant-related mortality, the double cords with SIBs being the gold standard here still are higher. So you can see that your risk of TRM is highest if you're a double cord, followed by mismatched unrelateds. Again, this makes sense. The double cords are very highly mismatched grafts. And then SIBs and matched unrelateds underneath there. However, the relapse rate is also very much lower in this patient population. So what this really, again, so you can see here, these all sort of overlap here. So relapse is about the same in all of these groups. Surprising that the mismatched unrelateds were not a little bit further down, but the double cords really still stand out. And one of the questions was, is that because they're dying before day 100 and they're getting censored out of this? Was this a bias on the part of the analysis, or was it something about being high risk patients or low risk patients? So when we looked at this, if you look at donor type, for all comers, the double cords were far less in terms of their relapse, their risk of relapse, you can see here. So again, matched SIB is the gold standard. But even if we looked at this in terms of breaking the patients out into whether they had high risk leukemia or standard risk leukemia, it didn't matter. The relapse rates were still lower even if you had high risk disease. So again, this is very encouraging. And what this means in the end is that these patients really there's no real difference in either of the stem cell sources when we compare them to double cords. And if we can improve TRM, we might actually improve the overall survival of the cords. So that's what I say here. In summary, leukemia-free survival with double cords after myeloablation is similar between SIBs and adult unrelated donors. We have increased TRM in the cord blood population, but decreased relapse. And this really begs the fact that we need still strategies to overcome the low cell dose, and we need to enhance hematopoietic recovery. Hopefully, by doing that, we can reduce the TRM. We also would like to better understand the biology behind the reduced relapse rates. Okay, so Protocol 2044 is my baby for a while now. This is the ex vivo expansion trial, and I'll give you some detailed results on that. So the objective of this is a phase 1 trial. No one's expanded notch-mediated cells and infused them into patients, so we had to start as a safety trial, although really our primary objective and what we really wanted to know about was here, examining the kinetics and durability of hematopoietic reconstitution. We can track these units because they're two different donors, so we can look at this and follow the contribution to engraftment from both the expanded and the non-manipulated grafts and be able to look at outcomes there. Again, our goal was to provide cells that could rapidly engraft and overcome the delay in hematopoietic recovery. It wasn't necessarily that we felt we'd have a long-term engrafting unit there. Here's the treatment schema. It's based on the double unit platform developed by Minnesota. So this is a very logistically difficult trial to run, both emotionally and technically. You can imagine that when I did the first patient, I don't think I slept for 16 days until the cells went into the patient. So you can see here that what we do is a patient comes here, it's decided they need a cord blood transplant, and we identify 2 units based on cell dose and HLA. So these are units that are picked specifically for the patient. They're frozen, they're delivered from the cord blood bank, and we take the one that was selected for expansion, and on day -16, we initiate cultures in the lab. So the problem with this protocol is you have a unit, you thaw it on day -16, and you get what you get, right? And you get what you get at the end too. So not all these cells grow the same. So it's a very nerve-wracking trial for the techs who are doing it too, because we all want these cells to grow very well. The other thing is that there's 8 days here where we've started the protocol for the patient, but the patient hasn't yet started conditioning. These are very high-risk patients. If they get a fever, if they get sick, and their transplant's put on hold, well, we've already thawed that unit and put it into culture. So thankfully, we haven't run into any problems with that, but that week is very stressful for me. So they start their conditioning on day -8. Again, it's a high-dose preparative regimen. It's myeloablative. These patients, generally speaking, who get this type of regimen have pretty horrible mucositis. Most of them require pain control. They require TPN. And one of the things we wanted to look at is whether we could abrogate that. On day 0, we give the unmanipulated unit first. And this is T-cell replete. So that's the other thing to keep in mind here. So even if we have long-term repopulating cells that we have cultured in the laboratory, the thought was that when we give it in the presence, so the cells that we grow in the lab do not have T-cells there. We have removed them essentially by enriching for 34 cells. So in the end, when we look for T-cells, there are none there. There are no bystander cells there that have made it through the culture. So there are no CD3 positive cells there. So when we give this unit, it doesn't have an immune system associated with it. The other unit does. So it was expected that even if we could get this initial wave of engraftment from our expanded cells, that it would be rejected once the other unit came in. And that was fine as long as it gave a nice early wave of engraftment first. We wait 4 hours really so that we can track any toxicities that are associated with infusion of the expanded cells. After transplant, we look as early as day 7. Some of you may see these samples come through the lab. So we look at day 7, even if the white count is still 0, and we cell sort for CD3, 33, 56, 14, and 19, and look for contribution to engraftment in all of those peripheral blood sorted populations. So we look weekly for the first month, and then we space out the times that we look. Here's the patient characteristics. We're actually now up to patient 11. Sorry, this is a little behind. We've only done 2 pediatric patients. We did do 1 3-year-old because he had a history of fungus coming into transplant, and we thought, well, if anyone would benefit from rapid recovery of white cells, it would be him. Most of them have had AML, and they've been very high-risk disease patients. The other thing is that most of them have had very mismatched grafts. So here is the increase. This is the in vitro data from these 11 patients. So what you can see here is that the average fold expansion for the total nucleated cell dose is 562, ranging from 146 to 1,500. So again, you can see that really they don't all grow equally. So there is quite a range. And the CD34, we averaged 165-fold expansion, ranging from 41 to 471. And really what this means is that if you concentrate here on the CD34 cell doses, if you remember from the beginning, I said that the nice goal for CD34 is the hope of getting about 170,000 CD34 per kilo. That is the goal in a conventional cord blood transplant. So if you look at these units, on average from the unmanipulated unit, these patients had a nice 240,000 cell dose. But in the expanded unit, after expansion, the patients averaged 6 million CD34 per kilo from that 1 unit of cord blood. So that is on par now with a peripheral blood stem cell transplant. And we were very excited about that. And really, this is the punchline of what it showed. So when we compared the patients undergoing our conventional transplant, same regimen, same everything, just 2 unmanipulated grafts. So there's 20 patients in this analysis here. You can see that the median time was 26 days to neutrophil recovery of 500. However, when we then look at the expanded population, N is 10 here because one patient rejected both of his grafts and actually had primary graft failure. But out of all the other ones, the median time to engraftment is now 14.5 days. So we've significantly reduced the number of days to achieve an ANC of 500. Now, this patient here, that's the outlier. Interestingly enough, this is a pediatric patient who got a very nice cell dose. However, she had HHV6 reactivation very early on post-transplant, and we think that affected the expanded cells from engrafting. And so she is the only one out of the cohort of 10 that engrafted that never had a contribution to engraftment from the expanded unit and took 34 days to engraft. Everyone else who had an initial wave of engraftment from the expanded cells all engrafted within 21 days. So we've narrowed the range significantly. And importantly, you can see there are 3 patients here who engrafted before day 10. The amazing thing about these patients who have gone through this is many of them have not required PCAs, many of them have patient-controlled anesthesia, many of them have not required TPN. So their regimen-related toxicities early post-transplant really do seem to be less. This is reflected in this graph, the reduction in hospital days. Now, this is only in the adult population. I didn't include the pediatric patients. We keep pediatric patients in the hospital for a very long time for other reasons. So this is in the adult cohort of patients, and what you can see is on the expanded arm, so the patients who receive expanded cells were able to get out of the hospital earlier, on average about 10 days than the control group. So additional outcomes people usually want to know about platelet engraftment. We are seeing improvement in platelet engraftment. If you remember from the slide I showed you, the platelet engraftment at day 100, less than 50% of the patients had hit a platelet count of 50. And you can see here our mean time to platelet engraftment of 50,000 is 51 days. And then I've already really talked about graft versus host disease, but in this population we did have 3 to 4 GVHD who did respond to therapy. And our overall survival, we actually have had another death here, but we are mostly due to infection. So this has been actually interesting. We've had 2 patients out of the 11 who have actually shown in vivo persistence of our expanded cells, which we didn't expect. So what we really expected was that as soon as the other graft came in, our expanded cells would be rejected. So in one patient, patient number 2, at day 240, when we looked at her chimerism analysis, she still had a small percent of the CD14 population, 56, and CD19 from the expanded graft. There's no host here whatsoever. One thing that's important to note is that the CD3 in either of these patients, we never see de novo T cell generation from this graft. So in the instances where we've had in vivo persistence of the graft, we haven't seen T cell generation. And this is important for work we're starting to do now. Patient 6 was very interesting. She was truly a mixed chimera. So for whatever reason, her grafts were very mismatched to each other, ABC and DR mismatched, and yet they seemed to coexist together. And unfortunately, right after this time point, at 6 months, she was actually making type A red cells and type O red cells, which was not ideal for her. But at day 1, just after this time point, she unfortunately died from sepsis. But at the time, she really was a mixed chimera. So I don't know how long that would have lasted, but it was evidence to suggest that we do have longer-term repopulating cells that we are maintaining or expanding in culture. So we think that we have a system that's clinically feasible. I'm in discussions with the CIBMTR and trying to develop a national phase 2 trial to look at this. There is no infusional toxicities when we use this expanded cell product, and we know that they can contribute rapidly to myeloid engraftment and may facilitate the other unit to engraft, which is why we're narrowing the range down to 21 days. And in some cases, the expanded cells have persisted, suggesting there may be a longer-term repopulating ability of the expanded product. So let me tell you about some of my more interesting and frustrating existence of my life right now. So I'm working with Barda. This is the Biomedical Advanced Research and Development Authority. They are part of HHS. They're a newer branch of HHS, and their charge is to further develop medical countermeasures. So an announcement came out, this announcement that you see up here, looking for therapies that were already in trials that could potentially be further developed for use after acute ionizing radiation exposure, so for the hematopoietic compartment of acute radiation syndrome. So I decided to apply for this very large contract, which is very nice to have. And really what we started thinking about was, could we somehow make this trial easier to do? So we know we don't have T cells at the end after we expand these cells. So we take a unit, we 34 select it, It's very complicated. We lose a lot of the stem cells up front because it's a frozen unit. It's not easy to do. At the end, there's no T cells. And then we give this partially matched unit to a patient. Well, one of the things we wanted to ask is maybe you don't need to match these cells at all to the patient. Maybe we could take a fresh unit, working with our friends at the Puget Sound Blood Center Cord Blood Bank. Maybe we can collect fresh cord blood units, enrich the 34 cells there, and collect more of them because it's a fresh product, do our nice magic with our notch expansion, and in the end, freeze that end product. And by freezing that end product, then it's waiting on the shelf for the patient. So there's no issues of could they get an infection, all these other things. And then what we wanted to ask is, could you give it off the shelf without regard to HLA matching? If you can do that, you can potentially give it after acute ionizing radiation. So we wrote this up, and we got the money to do this. The first year was spent really optimizing our current manufacturing, but from fresh cord blood units, writing an IND, doing the work to show that when you cryopreserve the end product, the expanded product, that you can thaw it, still give it to mice, and they still give rise, they can still function in vivo. So we've done all that work, and we are about to open up a clinical trial. And this trial is not a transplant trial, which I have to remind everyone of because there's essentially allo cells being used here. But it's an AML trial where we want to ask, can we abrogate neutropenia with these cells in a non-match setting? We're also going to do some animal models to look at facilitation and use of these cells across HLA barriers. So this trial, I hope, is about ready to open. It's FDA approved, it's IRB approved, and now we just have a couple steps left, and hopefully we'll be ready to open in about a week or so. What we are going to look at, so I don't know how many of you are taking care of patients on the onc floor, but there's Pam Becker has a GCLAC trial, so using clofarabine. We are going to take that same backbone. This is a chemotherapy regimen that actually has prolonged neutropenia associated with it, and especially for older patients, they're at very high risk of infection. So we're taking that regimen and asking, after we give that chemotherapy regimen, can we follow up the next day with our off-the-shelf cryopreserved product, give it to patients, and see if we can get temporary myelopoiesis from this expanded graft. So for AML, induction is, we do know that the more chemotherapy, the more aggressive regimens you can give, we know this from pediatrics, the more dose-intensively timed therapy you can give, the better the outcomes tend to be. So this is why we're choosing AML. So we know there's prolonged neutropenia and immune suppression with this regimen, and there's risk of dying from getting these regimens. So if we can develop novel therapeutics that can abrogate this, we might be able to facilitate autologous hematopoietic recovery and then also help the patient go on to get more dose-intensively timed chemotherapy. So this is where the expanded hematopoietic progenitors come in. So why GCLAC? I've already addressed that some. It's profoundly immune suppressive and myelosuppressive. We wanted to pick a regimen that if these cells could work in this setting, that we would see that. We didn't want to pick a regimen where they would be outright rejected. There's prolonged neutropenia, frequent infections, and we wanted to, as I said, we wanted to see an effect of our off-the-shelf product. The benefit to the patient is they may not get infectious complications that will allow them to provide more dose-intense therapy and go on to maybe transplant if that's what's in the future for them. The primary objective here is safety. These trials were difficult to get through for good reason. People are afraid of the non-matched setting that we're using them in. So there's strict stopping rules associated with them. We also would like to assess the ability to provide this temporary myeloid engraftment and compared to the other cohort of patients, see if we can provide more rapid autologous recovery. We also want to look at the development of alloimmunization in case giving this product causes alloimmunization. So the inclusion is essentially a very high-risk group of patients. The first cohort are going to be relapsed refractory patients, and then progressively we'll move on to de novo better risk patients if we are seeing success. So we'll choose our expanded progenitor population based on nothing, so no HLA matching will come into play unless the patient has already demonstrated donor-directed antibodies, and then we will select a unit that doesn't express the antigens that they're directed against. So again, hopefully putting ourselves in a good situation to not have immediate rejection based on donor-directed antibodies. We're not going to have a cell dose limit on the CD34, but we do want to not exceed about 1 × 10⁹ TNC per kilo of the expanded cells that are in the freezer. This is kind of confusing. I don't think we really need to go through it, but essentially patients will be eligible for cells, or magic cells as Eli SD likes to call them, after their first cycle of GCLAC, and if they respond, they'd be eligible for a second cycle with cells. If they don't respond and they go on to get further therapy, it would be without the expanded products. So we don't really need to go over that. So we're going to be looking at essentially standard of care stuff, but we will be doing the same kind of analysis on these patients as we do in our cord blood transplant recipients, looking at engraftment studies early on, and if we do have engraftment, which we don't think we will have any kind of long-term engraftment, but if we do, we'll follow it until it's gone and look for uncontrolled GVHD or any infusional toxicities. This is just to show you that we have done the studies. So this is, again, all these little dots are individual mice that we've looked at. These mice received cells that were expanded and then cryopreserved until we then thawed them and put them into the mice. And it just shows you, again, this is human CD45% in the marrow of individual mice. And these cells still do engraft after they've been cryopreserved. Okay, so I always have to end by thanking my patients because they're really my heroes. These patients are, except for her, she didn't get the expanded cells, but she did get a cord blood transplant, and she's really cute. And she's from Alabama. So these patients, as you can see, one of the few times I come over here to see the patients is when I'm bringing the expanded cells. This is patient number 1. He really is my hero because he took the step with me and he didn't know what the heck was going to happen. So I owe a lot to him. And these are other patients who are also on the trial. She just came back for her 3-year follow-up and looks fantastic. And he just moved to Korea. So I have to definitely do some acknowledgements. As I said before, I don't do this in a vacuum. There was a lot of work before I even came on the scene. Irv Bernstein, Fred Applebaum, and Shelley Heimfeld have been instrumental mentors and people who have done this with me. And then I have a whole bunch of other people to thank, especially the moms who donated all the cord blood to me. And we have a lot of funding support from the NIH and NHLBI and others. So thank you very much for coming and listening.
Any questions?
Yeah.
So from the double cords, how do you pick which one to expand? And is it just the smaller original HLA?
That's a great question. So initially, when I wrote the trial, it was the smaller one. And then after, I think, we had 2 patients come. So the donor selection, so we know that you need at least 2.5 TNC per kilo to be an adequate graft. So because we had no idea whether the cells we put into the patients, the expanded cells, would actually contribute to engraftment, I designed the trial very stringently, and which is why many adults don't qualify. They're unmanipulated. They need to have one unit that is at least that 2.5, okay? And then they can have a unit that's smaller than that, and in those cases, we use a smaller unit. If they come to us and say they have 2 4/6 units, one is a 2.5 and one is a 5, then we would just expand the smaller one again. But if they have 2 units that are both above the 2.5 cutoff, but the smaller one is a 5/6 and the bigger one is a 4/6, we expand the less well-matched one because we pretty much know that that is likely not to be the winner. We want to manipulate the situation so that the better matched unit is the winner. So that's the only time we use a larger graft. But there does have to be a bare minimum 2.5 to actually be the unmanipulated graft. Yeah.
As another strategy of getting more cells, what about using 3 or 4 cord blood units?
People have done that, and they haven't shown it to be any benefit. Now, to be fair, that was done many years ago, and things have changed a lot in supportive care. I mean, some of the results, I think, are because we have voriconazole now, because we have great antivirals. And so, I mean, it might be worth looking at that again. I think if we can better understand the double unit and really what role that's playing, then you could potentially pick donors based on that interaction. Or, in theory, if it really is something about that cord that helps the other unit to have enhanced GVL, you could potentially give a cord to a standard marrow transplant. Maybe if you knew that interaction, you could say, well, you know the cord won't win, but it doesn't matter as long as it enhances GVL. So I mean, I think that's why we need to understand that, because you could then use it in many, many different settings. Maybe you could make the match SIB setting better.
And in terms of the expanded cell populations, why don't you get T cells then?
Yeah, you know, I don't know. I think probably it's because the other unit is there. Now, if I gave the expanded cells alone, which I'm too afraid to do, But if I did that, maybe we would actually get T cells there. It may have something to do with who actually gets to the thymus first, what kind of reepithelialization that happens there, the DC cells that are present there. I don't know, but clearly at 6 months, we still, and 240 days, there were still no CD3 positive cells from our expanded graft. We should. We're making everything else, so you would think that we would have that.
Do you know if there's some sort of mixed lymphocyte reaction that's going on inside?
I don't. We talked about trying to do that, but we haven't yet, so I don't know.
For your leukemia trial, the one you just presented, 2 questions. How do you choose which of those fresh cords you're going to expand to just put on your shelf?
Oh, that's the beauty of it.
And then the second question is, you showed the mice that they do engraft. When does it go away? Because you said you're quite sure it's going to go away. When does it go away?
Okay, so for the first question, if we can really do this in a non-match setting, then it doesn't matter what fresh unit we use. It could be, as long as we have enough starting CD34 cells there. So, the more you start with, the more you get at the end, right? Just mathematically. So it doesn't matter. If you don't need HLA typing, you could generate a usable bank of cells very rapidly, right? Because so many of them are thrown away. Or you could potentially, now this is crazy, but I think the FDA thinks this is crazy, you could potentially say, well, in order to make, because this is expensive too, we can spend up to $50,000 expanding a unit of cord blood, right? We've gotten that cost down a lot because we've reduced the cytokine costs, but if you could potentially take 10, 20 units, pool them all together, be able to select the 34 positive cells easier, because most of the selection devices are for larger volume. So if you could combine them, then you could make a whole batch, maybe of like 100 doses, and then you'd have a consistent, product on the shelf. Right now it's, one gets expanded. We can make doses. We don't really know what a dose is, but we'll freeze up to about 4 billion cells per bag, and a couple of the units we've expanded have given us more than one dose. So the hope is that you don't need to match, and then it's a very feasible thing to do for many different purposes. For the mice, we haven't looked to see how long out. Now, this is in a non-competitive setting. It's in an immune-compromised mouse. It's a very immune-deficient mouse model. So I'm not sure that we would see the same kinds of kinetics we would see in a human setting. So we'll know very soon whether they persist. I just can't believe they will, but who knows? That's why we're doing it.